Okay, welcome to this session on inequities during the COVID-19 pandemic. I'm Robert Rodriguez, and we have 4 excellent posters and presentations. And as we all know, it goes without saying that the COVID-19 pandemic has exposed great inequities and disparities in healthcare throughout the United States. And this session is going to discuss some of those, how to address some of those inequities. And again, we have four great presenters. I'm excited to be here. And let's go ahead and jump right in with Amity Eliaz. And her presentation is evaluating the impact of language concordance on contact tracing outcome among Spanish-speaking adults in San Francisco between June and November 2020. And so take it away.
Thank you so much for the introduction. Good morning, everyone. So during the first year of the pandemic, I was a contact tracer for the San Francisco Department of Public Health. And through my daily phone conversations as a contact tracer, I saw these pervasive patterns of social determinants leading to significant disparities in access to resources, exposure to COVID-19, and in the ability to safely quarantine. In San Francisco and in California, we saw the disproportionate impact of COVID-19 on Latinx communities and the challenges faced by individuals with limited English proficiency in accessing important resources. And data from early in the pandemic response in San Francisco showed that Latinx individuals accounted for approximately 70% of COVID-19 cases, despite representing only 15% of the population. 85% of those cases spoke Spanish as a primary language. In response to these findings, we explored the impact of language concordance, known as health worker or clinician fluency in a patient's primary language, on contact tracing outcomes among Spanish-speaking adults in San Francisco. For our methods, this retrospective quantitative study evaluated contact tracing surveillance data collected from June to November 2020. Our subjects were Spanish-speaking contacts age 18 and older living in San Francisco. We initially assessed the relationship of language concordance with sociodemographic and clinical characteristics of contacts, including factors such as age, race and ethnicity, gender, housing status, symptoms, pre-existing conditions, and so on. We then estimated the odds of 3 contact tracing outcomes for our primary outcomes among Spanish-speaking close contacts reached by language concordant tracers who were fluent in Spanish compared to contacts reached by non-concordant tracers, both before and after adjusting for calendar time. Using logistic regression, we explored the impact of Spanish language concordance between close contacts and contact tracers on the odds of 1, contact tracing interview completion, 2, follow-up COVID-19 testing, and 3, access to isolation and quarantine, or INQ, support services that are often really essential to quarantine. And these include things such as food, housing, and personal protective equipment. For our results, 2,668 Spanish-speaking close contacts were reached, 70.4% by language concordant tracers, and 29.6% by non-concordant tracers. There was no association between language concordance and any sociodemographic or clinical characteristics. There was, however, an association between language concordance and calendar time. And if you look to figure 1, which is in the center, you'll see a chart of the proportion of contacts reached by language concordant or non-concordant contact tracers over time in months. And you'll notice that the proportion of contacts reached by language concordant contact tracers increased over time, while the proportion reached by language non-concordant tracers decreased over time in the pandemic response in San Francisco. For our primary outcomes, if you looked at table 1, you will see that there was no association between language concordance and interview completion. There was, however, an association between language concordant contact tracing and COVID-19 testing, as well as isolation and quarantine support service referrals. More specifically, the odds ratio for COVID-19 testing was 1.2 for contacts reached by language concordant tracers compared to those reached by non-concordant tracers, and 1.5 for isolation and quarantine support service referrals. And after adjusting for calendar time, the odds ratios were 1.19 and 1.49 for COVID-19 testing and for INQ support service referrals, respectively. In conclusion, contacts reached by language concordant tracers had 20% greater odds of completing COVID-19 testing and 53% greater odds of receiving INQ support service referrals. The proportion of contacts that were reached by language concordant contact tracers increased over time, as we saw in Figure 1, over the course of the public health response to COVID-19 in San Francisco, which really points to the rapid expansion and adaptation of the SFDPH public health efforts in response to health disparities seen in San Francisco. Overall, our findings really underscore the importance of mobilizing a culturally humble, language concordant public health workforce in order to address health disparities impacting communities with limited English proficiency, and to ensure that Spanish-speaking communities have access to public health services and really essential resources now and also in advance of future pandemic threats. I'd like to say a special thank you for the contact tracing department leadership at SFDPH and to the data team at the UCSF Pandemic Initiative for Equity in Action, and of course, for the tireless work of the contact tracing team. Thank you so much, everyone. What questions are there?
Yeah, so that's a great presentation, a very real world application of, as you say, concordant, the need for concordant language contact tracing. Did you I take it over time that DPH saw these results and acted on it? Is that what you found?
Yeah, so it's really interesting. I think SFDPH did a really amazing job responding when they witnessed these inequities and the disproportionate impact on the Latinx community. And really, we only had the chance to evaluate it later on because this response had to happen in real time. So we ended up evaluating it several months after this took place, which is what you can really see. You can see the response in Figure 1.
Yeah, that is a very nice figure. I like that. Another question is, did you look at any of the Chinese language, Cantonese or Mandarin? Was there any look at that as well?
A really great question. We actually didn't have data on that specifically. What we collected data on specifically was Spanish language concordance. Yeah. But that is another very important area as well. Thank you for asking that question.
Yeah, I think, again, this is, again, highlights the need for concordant language. And we see that every day in clinical settings. And essentially, this is a clinical setting. Thanks for the great project and really nice presentation. Anybody else have questions? Okay, let's move to the next presentation, which is Joe Graterol. And I have to, full disclosure, I'm a part of this, an investigator on this study as well. Joe's an assistant professor in Department of Emergency Medicine and great faculty in our department. So take it away, Joe.
Thank you so much for the introduction, Dr. Rodriguez. Certainly, feel free to chime in at any point given your involvement in this study. But I'm privileged to be able to talk to you all about the work that we did with this project, specifically the rapid evaluation of COVID-19 vaccination in emergency departments for underserved patients. So to start us off, essentially the impetus of the study, or essentially the study conception, back at the end of the year 2020, and after the first year of the pandemic, we understood a couple of things. We understood that one, COVID vaccines were coming and that they were likely to be the most pivotal of tools in terms of combating the pandemic. And the second thing we knew is that we were concerned about the possibility of vaccine hesitancy, specifically as it relates to specific populations that have been disproportionately affected by COVID-19, as our prior presenter had very beautifully highlighted. So in terms of what we tried to answer with this study, there were basically a couple of points. One, we wanted to understand whether there was vaccine hesitancy in our emergency department population, and two, whether the emergency department could play a role in blunting the effect of vaccine hesitancy by providing vaccines to patients, specifically those who use the emergency department as their primary source of care. So in terms of the methods we used for the study, we basically designed a cross-sectional survey, which was conducted between the months of December of 2020 and March of 2021. And we administered this survey across several EDs, 15 specifically across the United States. Several inclusion criteria, mainly or basically all adult patients, ED patients. And the exclusion criteria you can see down below include mostly acuity of condition, such as alternate mental status, critical illness, but also other characteristics such as patients who are incarcerated or transferred for other facilities. So in terms of what we did, we have the survey contents themselves. We asked about three main components. So if we go up to the survey instrument, for one, we looked at vaccine hesitancy, and we asked that question in the following fashion: would you accept the COVID-19 vaccine when it becomes available? With the potential answers being yes, no, or unsure. And with no or unsure being indicators of likely vaccine hesitancy. And that's how those were coded. And then we also asked a separate question of, if you do have concerns about the COVID vaccine, what are your reasons for not accepting that? And we will have some results about that below. Then we also looked at the regular source of care for our patient population. So specifically whether they have primary care providers or whether they use an alternate source, such as an urgent care or emergency department as their primary source of care. And then finally, if they were to accept the COVID-19 vaccine, where could they access it? So do they have a primary care physician where they think they could get it? And would they get the vaccine as part of their care in the emergency department if it was offered? So in terms of the results that we obtained from this study, you can see them below in this figure. Essentially, the couple highlights are that out of the patients who were surveyed or approached, we had a total of 2,300 patients who participated, which is a response rate of about 89.4%. Of those patients, a significant number lacked primary care providers or didn't use a primary care provider as their primary source of care. Out of those particular patients, many of those, the vast majority, use the emergency department as their primary source of care, which was not something that we found particularly surprising, as it was substantiated in other literature. Furthermore, in terms of what we were looking at, vaccine hesitancy, the question of vaccine hesitancy, 39% of patients approached reported COVID-19 vaccine hesitancy. And we'll see in the figure the various breakdowns of hesitancy across different EDs. But for our patient population, for the general, Zuckerberg general, we had about a 40% hesitancy rate, whereas in the Parnassus ED, we had 28%. Another thing of note is that patients without a primary care provider were more commonly vaccine hesitant as compared to those who did have a primary care provider as their primary source of care. And then lastly, of those who stated that they would accept the COVID-19 vaccine, good proportion, 79%, said that they had a primary care clinic where they could get it. but an even greater majority said that they would accept the vaccine as part of their ED care or emergency department care if it was offered there. So if we go up to the figure 1, probably have to zoom in a little bit, but essentially you can see the various EDs or emergency departments in which the survey was administered, in which the study was performed. If you look at the black diamond indicator icon, you can see the vaccine hesitancy rate of the various institutions. So at the top, UCSF Parnassus having the lower percentage, at the bottom, Cooper University having a percentage of about 50%. And in addition, we also see a couple other indicators. One on the left, you can see the blue icons indicating the proportion of patients in the emergency departments that lacked a regular source of care, such as a primary care provider. And out of those particular patients, the yellow triangles indicate the percentage of those patients who use the emergency department as a usual sort of care, the source of care. And that's where you can see the high percentages, anywhere ranging from a low of about 30 to a high of above 80%. So if we go to the next figure, this is table 1, reasons for not accepting a COVID-19 vaccine. So again, this was another key feature out of the patients who expressed vaccine hesitancy. We were questioning what were the likely reasons for not accepting it. As you can see, the top concern was concerns about side effects and safety, followed by need for more information. The next category was a question of misinformation, and then questions about not believing that the vaccine would work or not being worried about getting the COVID-19 virus in the first place. And you can see we stratified that based on patients who had a primary care provider or regular source of care versus those who did not. If we go up to the conclusions and limitations, certainly this was a study that was performed in mainly urban academic emergency departments, so it may not be generalizable to patients outside of this type of environment. There is a concern for social desirability bias in the setting that you're asking patients whether they would perform a particular health activity. Oftentimes, a social desirability bias may increase actually the number of patients that say they would get or participate in that sort of health activity, even though they might not in reality. Finally, the landscape of COVID vaccine knowledge and hesitancy certainly has evolved since we've administered the survey back in the beginning of this year. And certainly we've seen how vaccine hesitancy has taken hold and how it is disproportionate amongst different groups. So, certainly we didn't have that knowledge at that time. So finally, in conclusion, these are some of the key highlight points from our study. Nearly 1 in 2 of those without a primary source of care as a primary care provider use the ED as their regular source of care, and those were COVID vaccine hesitant. Over 1 in 5 of those who would accept the COVID vaccine reported that they did not have a clinic or doctor, and 95% of vaccine acceptors would accept the COVID-19 vaccine as part of their ED care, meaning that emergency departments, at least based on our results, were positioned to reach those without a regular source of care and who may be vaccine hesitant and otherwise may be unable to access vaccines because of that barrier. So I'd like to go ahead and thank our group of researchers that did an amazing job across the country performing their surveys and compiling this data. And I'd like to open it up for questions.
Yeah, thanks, Joseph. That was a really nice presentation, very on point. As we, I think my first question would be, have you, in your shifts in the ED, have you noticed a change in vaccine hesitancy, do you think, over time?
Certainly in San Francisco, we've done quite a remarkable job at identifying the concern of vaccine hesitancy early, specifically amongst our populations at risk or populations of color. There's been an enormous amount of outreach that's being done to mitigate it. We've been lucky, and for example, in this study, we identified a hesitancy rate of about 30% for Latinx patients, but we are well above the 80% mark for vaccination rate amongst our Latinx population currently. And I think that has to do with just the amount of outreach and the amount of both language concordant and trauma-informed care that's being performed out there. So in terms of answering your question, certainly vaccine hesitancy is something we still see in emergency departments. And I think there's things that you can do as a provider face-to-face with the patient in order to combat that. But I think overall in the Bay Area, we've done a reasonable job at identifying it early and applying the lessons we've learned to try to make things better.
I think that's an excellent summary of what's happened here in the Bay Area. Just groups all across the Bay Area have come together to address this issue. Of note, this study has led to a lot of programs, a lot of EEDs across the country instituting vaccines in their EDs and giving vaccine messaging as well. So thanks, nice presentation, really great job. All right, next we will be Leslie Giglio with workers' perspectives on COVID-19 risks, a qualitative study of Latino construction workers in Oakland. Take it away.
Great, thank you so much for the introduction. So to get started, we know that the essential workforce has been severely impacted by the COVID-19 pandemic, and the construction industry in particular, in which Latinos are overrepresented, has one of the highest COVID-19 prevalence rates across the country and especially in California as well. So, but few studies have qualitatively captured the perspectives and experiences of workers of COVID-19 in the workplace, which was the aim of this study. So to do this, we recruited construction workers from the Unidos en Salud community testing event that took place in the Fruitvale community in Oakland back in September of 2020. And in total, 19 Latino men, both English and Spanish speaking, agreed to be interviewed for this study. And these interviews were semi-structured interviews that took place from December 2020 to March of 2021. And kind of from this process, we were able to identify 5 major themes that came out of this. So the first being worries about COVID-19 in the workplace. We generally found that most of the workers, if not all, were worried about COVID-19 and just contracting it at work, as well as bringing it home to their families, as shown in this first little quote bubble. And the second was abiding by the rules. And again, we found that for the most part, workers were pretty much on board with the rules. They said they're okay, we're masking, we're social distancing, we're doing everything possible to protect ourselves at work. But an interesting kind of effect of this that we noticed was this idea of social isolation. So as a result of these social distancing protocols, many participants expressed feeling isolated at work, and in this quote, not really being able to share meals anymore, and a lot of them noting that they would actually eat their lunches in their separate cars or in separate corners. So just kind of identifying that lack of connection that they felt, especially at work.
The other 2 themes that we found were COVID diagnosis and disclosure. Sorry. So the other 2 themes were around COVID diagnosis and disclosure, as well as the lack of structural support that was experienced or perceived by the workers. So in terms of diagnosis and disclosure, one of the workers expressed that they had concerns when disclosing their symptoms. So they said, it was a bit like, what is going to happen to me? Will they lay me off? Will they scold me? What is going to happen? Am I doing good or bad by disclosing symptoms of COVID to their employer? And in terms of the lack of structural support, we found that workers were concerned about what financial supports they may receive or what was available to them in terms of paid leave or testing sites. And so here we have a worker who said that it had been about 22 days since they last called their local clinic for a test, for a COVID test, but had not been able to have a second one since the clinic had not responded to them. And so really what we found this to mean is that although workers were generally understanding and following the rules around social distancing and mask wearing, there was still a lot of lack of clarity in terms of what they had access to for financial support for them or their families should they be diagnosed with COVID, as well as just general concerns with what the protocols in place were for individuals that would then test positive. And so really what we summed this to be is that making workplaces safer requires not only abiding by the rules set for preventive measures, but also letting workers know what they have access to, and really communicating this both to workers and their employers about what the current workplace guidance is for COVID. And so to put this study into context, we think that this complements the quantitative studies that have shown what the different infection risk rates are for essential workers. Although we know that this is one of the limitations to our study is that the time frame was between December and March earlier this year. And so as with all COVID research, things are constantly changing. But then the overall policy implications, I think, still apply as guidance continues to change. And so for that, we think that our studies highlight the need for better outreach to workers on existing policies following a positive diagnosis. So again, with regards to job protection, with regards to regular testing centers or resources, and any financial support available to them. We also, one thing we forgot to mention is that many of our participants came from smaller informal businesses. And so what we found there is that there's also a need for additional resources to support adherence to the COVID-19 workplace policies within these small businesses. And so, I mean, the importance of this moving forward is that as guidance continues to change, or as there continues to be added guidance around vaccine and regular testing, it's important to really provide these kind of information to both workers and employers. And with that, we would like to thank all of our participants and all of our collaborators for this study. Thank you.
Thanks, Erika and Giulio. That was a very nice presentation. I really like the use of quotes. Often with this type of research, it's the best way to communicate some of the findings is through direct quotations, as you put in here. I guess my first question is, were you able to relay some of these findings to workplaces, or what would be the kind of the next step in terms of communication of your findings?
Yeah, that's a good question. So we currently have a manuscript under review. We completed that and submitted that. But in terms of next steps, so one of our collaborators, Laura Stock, works with the UC Berkeley Occupational Health Program, Labor and Occupational Program at UC Berkeley. And so we think that this could be a part of just a larger push for, potential guidance for employers. But that's still a little up in the air right now in terms of what those next steps look like for a greater push or greater visibility of this to employers.
Yeah, these findings are really critically important to get out there, and I very much appreciate your ground level research approach. It's these populations are often difficult to study by traditional means. In other words, you can't go out and send an internet survey or make random phone calls to reach this target population. And so it really has to be on the ground like you did. So I commend you on this, your efforts on this study. Anybody else have any comments or questions? Okay, let's move to the next presentation. And so Aubrey, I'm not sure if you can put it to the next poster. Hang on one second, people. I'm sorry. Let me see if what forgive me for a second while we line up the next poster.
My apologies, my computer froze. Let me share my screen again.
Okay, sorry about that. Okay, so thank you. And the next presentation is Elena Portacolone. Hopefully I didn't butcher your name. And it's factors related to COVID-19 vaccine intention in Hispanic Latinx communities. Thanks.
Thank you. And this presentation really builds over the prior presentation of Dr. Meza and Giglio. So in the midst of the pandemic between April and July 2020, we decided to leverage a parent study on Latino communities that we were having. The focus of this parent study was on barriers to participating in research. And we just quickly organized extra focus groups, and we added questions in the interviews with CBO with administrators of community-based organizations in order to understand what were the effects of the ongoing COVID pandemic among Hispanic and Latino communities. And we especially wanted to understand barrier facilitators to vaccine intention at the time where the vaccine was not available, And this is still a pressing public health issue because even though more and more Latino and Hispanic individuals are being vaccinated, still most, around 60% of Hispanic and Latinos that are age 18 and over are not fully vaccinated against COVID-19 in the US. And so we, when I say we, I say a team of bilingual and bicultural Latino researchers who organized and managed these focus groups and conducted the interviews. So we conducted the focus groups in Fresno, in California, so looking at issues related to farm workers, and in Los Angeles. And so we organized 3 focus groups with a total of 33 participants, all Latino, Hispanic, age 18 and over. And then we conducted 12 interviews with administrators of local organizations serving primarily Latino, Hispanic communities. And we used the content analysis to analyze collaboratively the data. So the main finding was that there was this intention towards being vaccinated. Also, I don't know if you attended the presentation of Dr. Orlando Harris earlier. We were conducting these focus groups in Black American communities in Detroit and Bay Area, as well as these focus groups in Fresno and LA. And while in the focus groups in the Black American communities, there was a major resistance. We're talking about the spring, summer of last year, about considering being vaccinated. In the Latino communities, we found major barriers, but overall there was this major willingness to be vaccinated, and then highlighting these these key barriers to be vaccinated. So the first one was limited access to healthcare services. So related to having precarious or no employment, it was also considered difficult interacting with healthcare providers. Some of them were seen as government agents, which is a contribution of our study. And just to read you a quote related to the vaccine, is there is no guarantee that there is a safety net to catch you if you do test positive. So it's almost like you will be punished in a way if you test positive, not directly, but in other ways. So I think that's a bit deterrent. So there was a sense of not being supported healthcare-wise, and also not understanding whether the vaccine was going to be provided in what way by healthcare providers that were hard to reach anyhow, to access anyhow. And then the second barrier were financial concerns. So as we also heard earlier about being worried about losing earnings due to, for example, having to being tested, and then also what happens if then I'm tested positive, and same ideas related to the vaccine, also taking time. A major concern was taking how I can take time off work if then I have the side effects of the vaccine. So major financial concerns, and also not being able to be eligible for unemployment support and coronavirus relief funds due to immigration status. So which tags to the immigration matters, which is the third barrier. And so, for example, one focus group participant asked, if I show up and have a positive test, so we talk about being tested, will they ask more questions about my citizenship? So major concerns about being recorded a person is being tested or in the future being vaccinated. And then a major concern was that at the time in February 2020, the criteria for public charge, so the criteria for determining whether you can get a green card or not, were restricted by the Trump administration. That led to even more concerns about being tagged, and maybe if I get tested, vaccinated, it is a public charge, I can get a green card. So that was a major barrier. And then there was a general misinformation, confusing information, and also major evidence of televisions and Spanish televisions, as well as Spanish doctors dissuading the audience from being vaccinated, like Dr. Juan on TV say, please, don't be vaccinated, and same also messages on Facebook, and then also it was not clear. And the younger generations of participants said that the older generation live in this bubble of univision, and that they don't really understand what is going on. So to conclude, in terms of recommendations, it's really important, it's key to have federal and state government much more involved in reassuring and creating, making the vaccine as accessible, as well as testing, which accessible. There is a recent article from the American Journal of Public Health titled Farm Workers and COVID-19, and it was published in August, and they say that still in summer 2021, there is no clear federal policies related how to protect farm workers, which are mostly Latinos in the US. And then it's really important to have bilingual, trusted healthcare provider clinics. Again, this great article, American Journal of Public Health, talks about really creative partnerships in Monterey, here in California, as well as in Maine, between clinics, advocates, and employers in order to support vaccination and testing. And then also we presented our findings to the Community Advisory Board of Latino leaders, and they said it's really important to create a bundle of services to make vaccination as well as testing more attractive. And so providing free eyesight, blood pressure checks, maybe t-shirts, of course, also providing culturally relevant food. And I want to conclude with a word from Adriana Perez, who is the main author of this paper that I just submitted this morning to American Journal of Public Health, finger crossed, that every work in the US should benefit from federal COVID-19 relief program, including paid sick leave and family leave. So thank you very much. Open for questions.
Thanks so much. I very much appreciate this in-depth look at vaccine intention in Latinx communities. Your methods are very rigorous, and your findings are very helpful. They certainly add to the recommendations, the things that we should be doing for Latinx communities in this pandemic. I especially liked the recommendation about bundling vaccinations with other wellness services. That's a very logical and could be a very meaningful change that could be enacted from your work. I guess my main question is, did you had different groups of interviewees, the CBO administrators. Was there, did you find differences between what they perceived to be barriers and what the focus group interviewed, the Latinx population themselves? Did you find significant differences in what they found to be barriers?
Not at all. No, the stories really merge with each other, and it was really great to interview the CBO administrators later. So then we could go deep into the barriers that we found because we had much more time. They were one-on-one. So then we learned more about this. I learned particularly about the relevance of the change criteria in the public charge rules enforced by Trump in February 2020. So we went deeper. So there were same stories, but we managed to go deeper.
So they seem to have a pretty good grasp of what their patients
Yeah, very much.
their patients' concerns as well.
Yeah, very much so.
That's wonderful. Anybody else have any questions for Elena or Elena or any of the other presenters? This is very much an open forum. We'd love to have any questions if anybody has